I am Sally Karioth. Sally is Sally. Karioth is Karioth.
May I please the court?
You may proceed.
Thank you. Dr. Karioth, can you give us the benefit of your education, please?
I'm very old. I've been at Florida State for 40 years, and I started out with a degree in nursing and then went to the University of Wisconsin, hoping for a degree in musical theater, and then switched to medicine. And by then, my husband had taken a job at Florida State University. And so we moved there, and I went over to the School of Nursing and said, could I get a graduate degree? And they said, we don't have a graduate program, but we're one faculty member short. And do you want the job? And I wasn't doing anything else that day.
Excuse me, ma'am. I would object to the narrative. The question was about her education. We seem to be drifting off into other areas.
Stay. Doctor just limited it to your education, degrees, et cetera.
All right. Following my being hired, I went back to school. I got 2 master's degrees and a PhD and did some postdoc work in genetics at the University of London.
And can you tell us what your degrees are in?
I was a diploma nurse. I got an advanced degree in baccalaureate degree in nursing and a degree in musical theater. One of my masters is in foundations of education. My doctorate is in educational psychology. My second master's is in family nurse practitioning. So I'm an advanced registered family nurse practitioner. And then the work I did, postdoc work I did at London was in genetics.
And can you tell me what an advanced registered nurse practitioner is?
She has the ability to practice on her own with a umbrella effect of often, and I train these students too, they work in clinics where there is a physician that validates what they do. They can write prescription. In Florida, they can't write narcotic prescriptions, but they functioned doing all of the kinds of tasks that physicians can do, but they do it under the auspices of someone who works in the office.
All right. And can you tell me whether or not your license permits you to evaluate and treat individuals without a physician being in the room?
Well, because I do clinical counseling that doesn't involve medications, et cetera. If I have a patient that I think needs that, then I'll refer them out. But generally, the practice is independent. A great many of my patients come from physicians who refer them to me.
Okay, and are you a full professor at FSU?
Yes.
And can you tell me, please, the focus of the work that you do at Florida State?
Well, I'm the director of the Teaching Learning Excellence Part, which means as we get new kids in and new faculty, we teach them how to be efficient teachers. I teach 5 different classes on grief and loss and trauma. Some of you may have remembered that recently at Florida State, one of our students got a Rhodes Scholarship.
Objection, not responsive to the question.
Sustained.
Doctor,
Doctor, listen carefully to the question and answer only the question that is posed. Next question.
Thank you. Specifically, the courses that you teach, could you tell us the names of those courses, and could you tell me, please, how many years you have been teaching those types of courses?
Yes. My response was to this new course. I started with a class called Death, the Individual, and the Family, and that was in the early 70s. And I believed at that time may have been the first grief and loss course in the country. We added an additional course in the religion program. I had a clinical component to that original class, and HIPAA laws changed it a little bit because the students would have interacted with them in such a way that they could have been identified. I teach class called Ethnic and Individual Variations in Grief, Loss, and Trauma. And in the summer, where I teach in London, I teach a class called Grief and Loss in British Culture, Death, the Individual and the Family, and complementary and holistic medicine as an adjunct to end-of-life palliative care issues.
How many years have you been teaching grief or grief-related issues?
40.
And do you hold any certifications?
I'm a certified traumatologist.
And can you tell me, please, what that means?
We became this, following the Oklahoma City bombing, it became clear that there was no one to help the people that were first on scene.
Responsive to the question of what that means.
Sustain.
If you could just explain more narrowly what a traumatologist is and what it means to become certified in traumatology.
Traumatology is the helping arm, often of FEMA, I mean, we're part of Green Cross, that goes into places where there has been traumatic episodes, whether it be by weather or bombing, and our work is to interact with first responders in helping them to not either develop compassion fatigue or to be able to handle some of their secondary post-traumatic symptomatology.
And when you say FEMA, is that the Federal Emergency Management Agency?
Yes.
Do you have, in addition to your full professorship at FSU, do you treat patients?
I see patients, yes,
Yes,
and their
and-
families, yes.
How many years have you been seeing patients, and what do you see them for?
As long as I've been at Tallahassee, so 40 years, and then for patients that they themselves have been diagnosed with an eminently terminal disease, families that have lost someone and are really struggling to get back on their feet and are worried about other siblings, kids that are struggling with things at home, loss of job, anything that causes them to feel as though they're out of control in relation to how they're managing their feelings. But death and grief and big losses and trauma are the most likely reasons that someone would come to see me.
And can you tell me what organizations or types of individuals refer these individuals to you?
Well, physicians in town know that when they have a patient that's reacting in an unusual way, and he thinks that he or she may think that it's grief related, they'll call and say, "Would you mind seeing this patient?" and telling me what you think. And I do workshops for the police and for firefighters and for med students. It's part of their curriculum.
Objection, not responsive to the question.
What organizations refer?
Sustain.
What do you charge for seeing these individuals?
Well, I don't charge anything for seeing individuals.
And how many individuals do you think that you have seen and assisted in terms of working through grief-related issues in the last 40 years?
Oh, somewhere between 30 and 40,000 maybe.
Okay, and can you tell me who you trained under in terms of learning aspects having to do with grief and loss?
In the late 60s and early 70s, when I was at the University of Wisconsin, I read something that talked about, are we failing dying patients? And I did some research and found a woman from the University of Chicago area who was willing to come up to talk to med students in Wisconsin about her work. And she did. And she talked a lot about patients have the right to know their diagnosis. They have the right to
Objection.
refuse
Not
treatment.
Your Honor, could we approach and ask for an instruction to the witness? Chief?
I'll be glad to rephrase the question. I just need the...
Sustain. Doctor, listen carefully to the question and answer only the question that is being asked.
I need the name of the individual under which you trained.
I trained after that day with Dr. Elizabeth Kubler-Ross, who came up from the University of Chicago and worked with us at the med school in Wisconsin.
Can you tell me whether or not you've given any seminars in grief and trauma-related issues, and if so, how many approximately?
Well, I do maybe 50 a year, and 10 years ago I did 100 a year, and 15 years ago I maybe did 200 a year, so
Hundreds?
hundreds, thousands probably, yeah.
And to whom are you speaking on grief and trauma?
Physicians groups, nursing groups, pharmacists, clergymen, firefighters, EMT people, police, dog trainers, interestingly enough, people that go into sites where there's a lot of angst involved. So helping groups, social work students.
Can you tell me, please, approximately how many hours over your career you have spent studying grief and trauma and related issues?
Well, that's a lifelong event. I probably read new research or go through new books that are coming out on grief and trauma, certainly 5 to 6 hours a week.
Okay. And approximately how many hours, if you totaled up your time with regard to teaching, reading, giving lectures, working with individuals suffering from grief or trauma-related issues, what would be the approximate number of hours over your lifetime that you have focused on this topic?
Well, if I work 20 hours a week and there's, let's say 48 weeks in a year, times 40, what's that? Somewhere around 38,000 hours.
And what books, if any, have you authored with regard to grief?
I wrote Coping with Death and Dying, and if you want to know if you're dying, ask the cleaning lady. And I have been a contributor to the series of Chicken Soup books, and
The series of Chicken Soup?
and I did a piece not too long ago that Parents Magazine put out about explaining war and terrorism to children that they're using in foreign countries where there's a lot of terror and a lot of trauma.
Can we back up to Chicken Soup, because it sounds like a cookbook? What do you mean when you say chicken soup?
The Chicken Soup books that started maybe 15 or 20 years ago occasionally ask,
Objection to the relevance to her qualifications.
Could I just identify?
Overruled at this time.
Go ahead.
when those came out, they were really seen as a help book for everyday folks. And what they did is come to several people that they knew did different kinds of things and ask if we would tell one of our stories in the book about how people do get better. People can be dignified and can manage things. And so those little vignettes seemed to really ring a bell with folks that were struggling through some of the very same issues. And so that's what those books are. They're a set of short stories that are biographical for the most part.
Okay.
My objection to the relevance of Chicken Soup books to her qualifications.
And what's the name of the Chicken Soup book that you participated in?
Well, I see it out in lots of them. The original one was Chicken Soup for the Surviving Soul.
Okay. And have you authored any chapters in any books having to do with grief?
Yes, I'm on the editorial board for one of the trauma journals, and I edit other folk stuff that comes in. And then
Objection, Your Honor, not responsive. The question was, has she authored any chapters,
Yeah.
not edited?
Your Honor, I'm objecting to the speaking objections.
Objection overruled.
I have authored chapters that often have to be edited to fit in the space that they're supposed to be in.
How many chapters, approximately?
half a dozen more. I do more editing of other people's work to go into books.
Okay, and what is Compassionate Friends? And what is your relationship with that organization, very briefly?
Compassionate Friends is a now international organization that began in Illinois for a group of parents who had lost a child and felt that there should be support groups available for them. It is now spread all over the world, and we in Tallahassee have a chapter, and I was on its original board, and it's very active. And it's parents who meet with other parents to talk about those that are getting better, those that are getting worse, what kinds of things, and we try to break them down. And so parents of children who committed suicide or parents of children that died of a SIDS death. And so the research is pretty clear that
Objection.
groups.
Responsive to the question.
Sustain.
Dr. Karioth, tell me if you would, when you began studying trauma, could you get a degree in that, or could you get a degree in crisis intervention or things of that nature when you began doing your work?
No, that wasn't even a class in it. It was
Okay.
when Dr. Ross said, this is something I'd like to teach. That was the only even lectures in the country.
Now, can you tell me whether or not some of the work you have done has been responsible for classes and programs dealing with trauma in universities?
Well, we have several classes. I mean, the religion department has a class. We have a class in nursing. I see most of the pre-med students. There are classes in, I saw a survey the other day of something like all of the big schools around the country have, if not a specific death and dying or grief class, a crisis intervention class, how to deal with trauma classes. And so now it's pretty typical to have that kind of class in a normal college curriculum.
And did you have involvement in actually setting up some of the curriculums for the study of grief?
Yeah. Okay. Yes. One of the things that happens when there's a program and someone wants to start another grief program is they will go to states that look similar to them and ask us to send them a syllabus because they want to try to put a program together.
Okay. And I had asked you the names of organizations that have consulted with you or the types of individuals, and I don't recall if you responded. Can you tell me whether or not judges and pharmacies have consulted with you?
Objection.
Not relevant. Bolster.
Sustain.
Have you given testimony in cases as an expert in grief and or trauma in Florida or other states?
Yes.
And approximately how many times?
1 or 2 dozen times, maybe.
Okay. Doctor, can you tell me whether or not everyone grieves the same way?
Objection, Your Honor.
The witness has not yet been qualified. I have voir dire.
Are you tendering the witness at this time as an expert?
Yes, sir. An expert in grief and trauma.
Mr. Ashton, any objections?
Yes, I would like voir dire.
You may.
Good afternoon. Have you ever published any research studies in peer-reviewed journals on the issue of grief or trauma or death and dying?
Yes.
How many articles have you published?
Oh, half a dozen.
And on what subjects?
Compassion fatigue, compassion energy, end-of-life issues for children and how parents choose to dispose of their belongings, gay women with AIDS and their treatment in hospice situations.
And what are the peer-reviewed journals in which these were published?
Southeast Research Journal. After Katrina, we wrote a grant for.
Objection, Your Honor, not responsive. I just asked for the journals.
Well, I was going to tell you they were online journals, and the online journals
Okay, I'm sorry. Hold on a second. Southeast something journal? Say that again?
Research,
Research journal. And is that a peer-reviewed journal?
yes.
All right. Any other journals?
There are other, well, the book on the Parents Magazine book in which they chose those of us to write.
Well, Parents Magazines is not a peer-reviewed journal, is it?
Well, it was a book they wrote explaining war and terrorism to children, and they asked for input and then chose which folks they were going to use.
But is Parents Magazine a peer-reviewed journal?
It was a book, not Parents Magazine.
The book is peer-reviewed?
Yes, the book was peer-reviewed, and
Why-
it was sponsored by Parents Magazine,
By what organization was it peer-reviewed?
by the editors of Barnes and Noble.
Well, Barnes & Noble is a publishing house. It's not a peer-reviewed journal, right? It's a publishing house. Barnes & Noble, they publish and distribute many books. But what I'm asking for is serious peer-reviewed research journals that you have published. And you,
Your Honor, I'm going to object to the use of the word serious and counsel commenting on the qualifications.
I'm questioning her on her qualifications, Your Honor.
Overrule at this point.
So what I'm concerned about is, you know what I mean when I say peer-reviewed journal.
I do.
Okay.
And I know that when that book was proposed, they went around the country and asked folks that worked with kids who had been terrorized or in foreign countries to please submit an article that they thought would be appropriate. Then they read it among the reviewers and told us whether or not we were going to be included.
All right, but what I'm referring to by peer-reviewed journals is where you submit a journal article to a recognized journal in the field. It is then sent to other experts in the field for their evaluation and
And
comment.
those were the experts in the field that decided my work was acceptable. And I also sit on several of those journals.
Objection, Your Honor,
and look
not
at other
responsive
people's.
to the question.
Overrule.
Go ahead.
Answer the question.
That I'm an editor on several of the trauma journals in which other people send articles to us, and then we decide whether they can be.
But other than one article in the Southeast Research Journal, have you published any other in any other research papers in peer-reviewed journals?
Yes.
Okay, tell me what they are.
If you will give me my vita, I will tell you what they are.
I don't have it with me. Go ahead. If you need to refer to your CV to refresh your recollection, that'd be
Well,
fine.
I'm just going to go through this piece, if that's okay.
Just tell, if you would, simply tell me what the peer-reviewed journals are in which you have published research.
All right. The Florida Department of Health, nurses responding to assisting hurricane victims, PI, co-PI Sally Karioth, Deborah Frame.
Okay.
Implementation, technical report.
Could I just interrupt? I just want the journal. I don't need the name of the article. I just want the name of the journal. Just the name of the journal, please.
Okay. It appeared in the Florida Department of Public Health.
Okay, Florida Department of Public Health.
Mm-hmm.
I know that's the name of an organization in the state of Florida, but what is the name of the journal?
This is an online journal that they get via computer.
Is it peer-reviewed?
Yes.
Who reviews it?
The folks at the health department saw this particular grant and looked at it and responded to us and said, this is important work we want you to do. And then along the way, we had to write technical reports.
All right, but what I'm referring to is, as you know, peer review is when your research is done, it is submitted to other experts for
Right.
comment.
The experts got those so they could use this for this.
Who are the other experts, peers?
We don't know who
Okay.
who looks at our stuff.
Okay, what other peer-reviewed journal?
Healing adjuncts to the medical model and pediatric nursing manual.
Okay, that's the name of a book?
It's a chapter. Mhm.
No, what's the name of the book?
Healing adjuncts
Okay.
to the medical model.
And you wrote a chapter?
And I wrote a chapter, Managing Grief and Loss in Children.
And that is not a peer-reviewed journal, correct? That's a book.
Well, it's a book.
And what is the group that peer reviews that?
Pediatric nurse practitioners, the folks
All
that
right. What other peer-reviewed journals?
Dealing with Death, A Strategy for Tragedy, which is a monograph for educators dealing with a student's death in the classroom, explaining deaths to children appropriate to their developmental age.
Okay, what I'm concerned about is what is the journal? I don't need
Dealing
the
with
title,
death.
just the journal.
Dealing with Death, it's a monogram. Then the monogram that they put out each year for this particular group is like a set of articles.
I see.
And it's called the Monogram for Educators Dealing with a Student's Death in a Classroom.
Okay. Any others?
Dealing with the grief in a decision to donate organs, a support guide for families, and it's in Translife Organ Tissue Transplant Services to Family out of the North American Transplant Coordinators.
What is the name of the journal?
Translate,
Is that the name of the journal, the whole thing you just gave us? How often is this journal published?
it's quarterly, I think.
Right. Any others?
No, it's-
Your Honor, I'm sorry, at this point, I'd like to interpose an objection.
You may.
Now, you indicated that
continue.
you, security? Okay, thank you. You indicated that you had testified as an expert. Could we have counsel go ahead and sit down? I just, oh.
Continue, Mr. Ashton, please.
You've testified as an expert on grief. I put down one or two, but I know I wrote that down wrong. How many times have you testified as an expert on grief?
oh, I'd say at least a dozen.
12 times, approximately. And in criminal cases or civil cases?
Both.
How many of each?
Pretty close to half and half. And there was a maritime case in there too.
Okay, 6 civil, 6 criminal, and maybe 1 maritime. And on what issue were you testifying about in these criminal cases? As to what issue?
The amount of trauma suffered by the victims.
Relevance does not go to voir dire.
As to the last question, it does not go to qualifications, so it's sustained.
Well, have you ever been called upon to testify or give an opinion as an expert on grief in a situation where you had never interviewed anyone involved?
Yes,
And in how many occasions have you done that?
one.
And what type? Was it the civil case or the criminal case?
It was both.
You may have to explain that to me. You said one, but
It was a child sent to a boot camp who eventually died. And the criminal case was what was done first, and the civil case followed that,
and you were talking about trauma to the victim that died.
to the victim.
And did you interview people in order to render that opinion?
I interviewed a sister.
Did you also get report information and other anecdotal information?
Yes, I did.
No further
I'm sorry.
questions. I object to her qualifications in the context of this case, Your Honor.
Witness will be accepted as an expert witness in the field of grief and trauma.
Doctor, I just want to clear one thing up. You were asked about peer review articles. What are the journals of which you are one of the editors to decide what's good enough to be published in peer review articles?
Oh, the Journal of Traumatic Events. Several of the journals that come out of Charles Figley's work at LSU. I look a lot at the instruments that are going to be used in other journals as one of the things that a doctoral student, for example, may use as a tool in her original research about grief and loss. I do a lot of that. Work with the IRB board, which is the part of any university that decides whether the research that the students are going to do is valid. And
Okay. That's a good sampling. Doctor, can you tell me, please, whether or not everyone suffers grief the same way?
No, they don't. No, it's not that I can't tell you, but no, they don't suffer it the same way. If I were to poll the room, we would find that each of you do it differently. What I find in my own patients is just a plethora of differences in how they handle terrible news.
Can you describe some of those differences?
I work a lot with parents that lose children, and
Let me object to questions in general that don't involve the facts of this case as not relevant.
Let's approach the sidebar for just a minute. You may proceed.
Thank you. Dr. Karioth, I'd like to give you a hypothetical, and then I'm going to ask you a question about that hypothetical. I would like for you to assume that a 22-year-old mother of a young child, almost 3 years old, who has a loving bond with that child and is an amazing mother to that child, loses that child. That child dies. Could you please describe for me the demeanors that would be consistent with grief given that hypothetical?
Objection.
Pursuant to, pardon me, Harrison versus Byrd, 256 Southern Second 50. It is an
Let me see the case.
Sure.
May we approach?
Yeah. You may continue.
Thank you. All right, I'm going to ask the question again. I'd like you to assume a hypothetical in which a young mother, a 22-year-old mother of a young child, almost 3, who has an amazing and loving relationship with that child, a special bond, assume that that child dies. Can you please tell me what the demeanor or reactions one could expect, which would be consistent with grief, given that hypothetical?
well, again, since everybody does it differently, and I think that that's imperative because it's one of the ways that we decide how other people are doing in relation to how we would do ourselves. I certainly have seen mothers who have lost children that they had loving and wonderful bonds with go face down in the bed and stay there for months sometimes and not be able to get from the bed. They don't wash their clothes. They keep the sheets on the bed. That the way they deal with that event is to keep everything close. Conversely, I have seen parents, mothers whose child die, coming home, and we all know no one promises us tomorrow, so they don't make it home. They clean out the room, they give away the clothes and the toys and all pieces of that little one in the house are put away in a box or given away to Goodwill, and he's not spoken of. And often the parents will say, it was just too painful to have all of these memories. Well, another parent will say, it's some memories that are getting me through. And some people go to the cemetery every day, and some people say, it's way too difficult for me to go to the cemetery every day because I don't think he's at the cemetery every day. In younger adults, certainly among college-age kids, they have a tendency, they're reluctant grievers. They have a tendency to buy into the grief issue, and they often manifest very risky behavior. I mean, if they had a friend died who was drinking and driving, they might do the same thing.
Objection to testimony about types of grieving unrelated to mother and child, not relevant to this case.
Your Honor, may I respond and object to the speaking objections? This individual...
Objection overruled. Continue to answer the question, ma'am.
Well, if a mother's in a car with a baby and there is an accident and the mother had been drinking, for example, it is I have certainly seen this in more than one occasion where instead of stopping the drinking, they may continue the drinking and have risky behavior. We sometimes call it survivor guilt, especially if the mother were to live and the baby were to die. But what I have found is that I've never had a single patient do it exactly like another single patient. And that is often unsettling for folks that look at other people's behavior and say, I would never act that
Objection
way.
to commentary about how other people view grieving individuals, not responsible.
Sustained.
All right, let me add to that hypothetical. Let's assume the mother who lost the child comes from a family who copes with stress and trauma by engaging in denial and non-communication.
Objection. Assumes the fact, not in evidence.
Your Honor, I can go through the list of,
Don't do that. Come to the sidebar. Rephrase the question.
all right, thank you. I'd like to add to that hypothetical some additional information I would like you to presume and add to. Assume that the mother is tiny in stature and weight, and assume that she becomes pregnant and her pregnancy is visible. Assume that the father explains the visible pregnancy as a result of her athletic pursuits. Assume that the mother explains the visible pregnancy almost 8 months as a result of a sedentary, the opposite sedentary job.
Objection. Assumes fact, not in evidence.
Overruled.
Assume that the mother's brother, the mother of the young child, the mother's brother knew that she was pregnant and approached the young girl's mother about it and was told to stay out of it. Assume that the girl's mother is a nurse and was not taken for a pelvic or OBGYN visit until she was 19 and already pregnant. Assume that the daughter tells her mother at the 11th hour, almost 8 months, with regard to her pregnancy. Assume that the family does not inquire as to who the father is until the birth of the child, although the daughter is unwed and living under their roof. Assume that the young girl's father is summoned to pick up a car that she has driven to an area in which it has been moved, and states that there is a smell of decomposition but in the car, but does not alert the police and does not contact his daughter, even though the statement is made that his daughter is missing. Assume that a family member, even though that family member knows that the remains of this particular child have been identified, still makes the statement that he believes that she might still be alive. Assume that the brother of the young woman is angry because he feels left out when the parents began to go and make efforts to look for the child, at one point being the remains, not discussing with him. Assume that the brother of the young girl is angry because he is not involved and there are not discussions with regard to the obvious pregnancy. Assume that the young girl's father tells law enforcement that he was concerned about his daughter, so he followed her when in fact information having to do with the vehicle and the sun pass indicate that she was not followed. Assume,
Judge, objection, that is not in evidence. That's
I-
what we do in this case.
believe that,
Go ahead,
I
finish.
believe Detective Melich did.
No, go ahead and finish your question.
Okay. Giving all those types of behavior, can you tell me, please, what that type of family environment, if any, what effect that can have on grief of the loss of a child.
Well, that was very complex. There are certainly two groups, if you'll give me a little leeway, two groups of ways that people grieve. Healthy folks with lots of family support and good coping mechanisms, usually haven't lost, have great grace and dignity, make the journey in what I would call a healthy way, and come out on the other side. I don't think we ever resolve a great grief, but I do think we reconcile to a life where someone we love isn't anymore. And when we deal with families where there's a conspiracy of silence, as it were, where the kind of the rules of the family might be don't talk, don't feel, don't share, translated, we don't air our linen for other people to see. And in those situations, it's very likely that the response to a traumatic episode would often leave other people difficult to understand what has happened.
Objection to comments on how other people would view. It's not responsible.
And this person would
Yeah.
do.
Just a second, doctor.
Witness not to.
Just a second, doctor. Wait till he finishes his objection before you continue. Have you finished?
I have, sir.
Okay. Sustain as the other people, doctor, just deal with the people that you've been instructed to talk about.
My hypothetical.
Yes, sir.
Yes.
Yes, ma'am. Thank
Yes,
you.
sir. That in hypothetical situations, we can see that denial is a great helper. The story that may have happened can be changed a little bit. It's in many of these situations like you describe, and the one that you've described right here, I could see that it would not be atypical for there to be no discussion or discussions that may not look unusual or aberrant, and certainly difficult to understand.
All right, let's add to that hypothetical some additional information. Let's add to that hypothetical that during the 31 days after that child is gone, the young mother leaves home, goes out, rents movies, goes shopping, goes out to a bar, gets a tattoo that, when translated, indicates beautiful life. That kind of behavior. Can you please describe for me the significance, if any, with regard to that type of behavior and grief reactions?
Well, there's more than in what you described. It would be important to look at the behavior of what everybody did in those 30 days. And what I often see in young adults, and in this situation, it seems very, very like other young adults, is they are reluctant grievers. Young adults are reluctant grievers, and they will often say nothing has happened. They will demonstrate risky behavior. They'll go out and do the very thing that their friend died from. They will drink too much. They may drug too much. They may, retail therapy is a big event among young women, and I don't know about this particular case, but let's say in this particular case, the thought that if I can acquire enough things, I can make this go away, and partying sometimes to the point of right on the edge of hysteria, which there's a real close bond between mad and sad. And they look very different, but they actually are both responses to a loss issue. And so when I look at young adults who have limited exposure with the world and appropriate kinds of behaviors, I see often risk-taking, repeating the things that happened to the person, looking like they're having such a great time, spending all kinds of money they don't have, getting into trouble, might be minor, but it's called bereavement overload. And when
I'm sorry, what?
Bereavement overload. And when someone has had loss after loss after loss, they'll then act out because they've decided that they don't want anyone to be near them because everyone that's near them leaves them. And so, and it doesn't, I know you all know that death isn't the only loss in the world. I mean, we walk such a fine line between our job and our
Let me
children.
object at this point to the narrative that has lost the train of the question.
Sustain.
How long, Dr. Karioth, can this type of behavior last? And when I say this type of behavior, I'm going to be real specific. This type of behavior appearing normal, appearing fine, no change.
Appearing
Objection,
fine
Your
to,
Honor, the witness has never testified that appearing normal with no change is an aspect of grief.
Your Honor, this is a question.
Overruled, she can explain it.
yeah, and we need to always distinguish between normal and healthy also. I certainly have seen there is a great difference between grief and trauma. We grieve by thinking what we lost, and at that point eventually get to a point where we're okay. With trauma, if we think about a trauma and it's so awful, we'll stop ourselves. And years later, if no work has been done, years later, if someone asks this person, for example, to tell the story would sound almost exactly the same, and the behavior would change very little because they got stuck on the trauma and weren't able to get that in a workable place and never got to doing grief work. Grief and trauma are two very different concepts. So I certainly have patients that have kept original grief responses for years and years and years.
And what do you mean when you say original grief responses?
They are just as, they may still be drinking, they may be self-medicating, they find themselves in a little nest. Their world gets smaller after a while where they're most comfortable, where there's not a lot of people around. Their affect is often distorted, and then people around think, this person isn't feeling about this at all. And that kind of affective hysteria, if you will, is such that it's their response to grief when they've come from an environment where they never had healthy coping mechanisms, and at the same time may have been told to never talk about things that happen in a family.
Have you treated individuals who have lost a loved one who have appeared exactly the same according to, for example, friends and family members as part of your practice, the day before and the day after the loss, and continue to appear that way for years afterwards?
Yes. I have seen people lose a child and make arrangements and then go to work the next day and the next day and the next day. I've seen children come back to Florida State who have lost a grandparent over the weekend and delve into sorority life and become a hotshot student or a very bad student, as though nothing has ever happened. Or if someone comes up and says something, I don't want to talk about that. Denial is a great tool for as long as you can make yourself believe what you're saying. Ira Gershwin once said, They tell me my brother is dead, but that
Objection, not
doesn't mean I have to
responsive to the
believe it.
question. That's,
Sustain.
So,
ma'am, Your Honor, could we have?
Sustain. Next question.
That's all I have, Your Honor.
Cross-examination.
Thank you.
Is being very, very happy consistent with grief?
can be.
Is being very, very sad consistent with grief?
Yep, there are three emotions, sad, happy, and mad are the three that we see most often.
Are there any variations on the continuum between happy and sad that are not consistent with grief?
Well, ask me that again.
Well, what I'm trying to figure out is every state of demeanor between very happy and very sad consistent with grief?
On the entire
Everything.
continuum. I think I would be remiss if I didn't say I have seen patients virtually dock in at any one of those levels.
So there is nothing about the demeanor in that way that is either excludes or includes grief. It can be anything.
It could be.
Okay. How about, how do I say this? Interest in sex.
Yeah, it's.
Is there any?
There's research that shows when you don't have words to make things better, sometimes it's a method of feeling better.
So basically anything on the continuum from a complete lack of interest in sex to promiscuity, all of that is consistent with grief.
Scope of the direct.
Overruled.
Is that your testimony?
Well, I think promiscuity is maybe taking it too far. I think that in the death of some folks who were very, very close, find that they will do things that they hadn't done in the first 40 years just for the comfort of it.
All right. So any reaction in terms of your sexual desire from promiscuity to frigidity is consistent with grief? Anything. Is that right?
There are not facts to support this, and I think it also exceeds the scope of the direct.
Overruled.
Is that correct?
I have certainly had patients who found that in the beginning, sex seemed to help them with their grief, and as they began to become a little more aware of their environment and the things that they're doing, realize that that probably wasn't the thing that was going to make them feel better.
What I'm looking for is, can you give me anything that is inconsistent with grief?
I can give you things that are inconsistent with healthy grief.
No? No. The question is there, the import of your testimony is to interpret certain facts as consistent with grief. That's your understanding of why you were called, correct?
Yes.
So tell me anything that is inconsistent with grief. Any type of activity, any type of attitude, any type of demeanor that you would agree is inconsistent with grief.
Well, again, if you're not going to allow me to say that I think there are healthy grief responses, and I think that there are aberrant grief responses that need intervention,
Right. I mean,
and I must put both piles together, then I would have to say anything could happen when someone has a great grief.
So no matter what hypothetical I would give you, you would say that could be consistent with grief.
I would probably say if it were something aberrant, that is consistent with inappropriate grief response.
Okay. But what I'm getting at is no matter what hypothetical counsel gave you, you would say it was consistent with grief because everything is consistent with grief in your opinion, correct?
Everything falls into a category somewhere along the line from pathological grief responses to healthy grief responses.
Now, can you, from a set of activities, draw the conclusion to a reasonable degree of expert certainty that a certain person is at that time grieving. See what I'm saying? Not assuming that there's a loss and interpreting it as grief, but can you do the opposite? Can you look at a set of actions, not knowing what came before them, and say, yeah, this is grief, or no, this is not?
Well, I have a tool that's used in medical schools called the Karioth loss inventory. And if someone came to my clinic and someone ran that loss inventory on them, and I looked at the symptoms that came up, and he had a bizarre set of symptoms. I'm losing my hair. My fingernails are falling out. I can't sleep at night. I've got the hiccups. Every Wednesday, I just don't seem to get out of bed. Plotted on the diagram of that, I may very well say, tell me about Wednesdays and who have you lost and what kinds of losses have you had in your past.
And did you attempt to apply that instrument to the facts of this case?
Well, I don't know the facts of this case.
And that's the next question I want to ask you. When were you first contacted about this case?
I got an email in, I will say, the end of May, beginning of June.
And are you aware that this trial started, the evidence reports started on May 23rd?
No, I didn't know there was a trial.
Now, so you got an email about testifying in this case, correct?
I got an email asking if I ever did expert witnessing about grief.
When you walked in that door for the first time this afternoon, what facts had you been given about this case?
None.
So when you walked in that door, you had no idea who Caylee Anthony was, how old she was, or who died.
I said at the time that I got the email. Now, I was living in London at the time, and it wasn't covered there. But when I got that, I didn't know who the name was at first. So I wrote and said, there's some people in Tallahassee that do this kind of work too. And then I didn't hear anything about that, and I got another note. And I thought, well, I need to look up and see who that is. And then I went, oh, yes, this is something from several years ago.
So did you look and research the facts of the case a
No,
bit?
I did none of that. London carried it not at all. It was in no newspapers, on no TV. It didn't appear anywhere. And I really thought it was just a general inquiry and didn't interact about it at all.
So my question was, when you walked through that door this afternoon, what did you know about the facts of this case? Tell me every fact that you knew about the facts of this case when you walked through that door earlier this afternoon.
That I was being asked to come and talk about general research associated with grief and loss and how it might affect individuals. And that this case seemed to be about a young girl who had lost a daughter.
Have you ever worked with women who murdered their children?
Yes.
In what context?
I worked the Susan Smith trial in Union, South Carolina.
And did you testify in a similar fashion or on a similar issue to what you're testifying here today?
I testified about how people who have an enormous amount of grief can often get confused and think that the people they love the most shouldn't have to suffer as much as they do, because they can't make the distinction between their own suffering and maybe the suffering of their children.
And that was in the context of helping people to understand why Susan Smith may have murdered her children.
Objecting that exceeds the scope of the direct.
Overruled.
Is that correct?
Yes.
Sidebar, please.
Yes. You may proceed.
Thank you. I believe we finished the question about Susan Smith. You refer to something called denial. as a reaction to the loss of a loved one, correct?
As one type of coping mechanism, yes.
Denial doesn't mean literally lying, does it? Does it?
Well, it certainly can mean lying to yourself.
Right. You emotionally pretend as if the person is still around, or you refuse to emotionally accept the loss, correct?
Yes, I mean, that's a form of it, but folks who use denial a lot and are faced with a profound grief or loss may very well develop what I call magical thinking until they can get themselves believing something that's different than what happened.
In other words, someone who, let's say, loses their father might convince themselves that he's actually in Europe on a trip.
Absolutely.
But those people don't also think that they're in Europe with their father. They're not delusional to that extent, are they?
No, but they may very well take a trip to go see their father.
But it would be unlikely for someone in denial to tell another individual that my loved one is in Tampa and I'm with her, when in fact you're not. That would be very unusual, wouldn't it?
Well, I'd have to know what started that.
Let me give you a hypothetical. Hypothesize that this 22-year-old mother, her child dies. She immediately, within half a day, goes to her boyfriend's house and, oh, I forgot to answer. This child dies and she doesn't tell anybody that the child has died. No one. She then goes to her boyfriend's house and rents a movie, spends the night, engages in sexual relations with her boyfriend that day. The next day, by the way, she lived with her parents. That's part of the hypothetical. Okay. She then sneaks back into the house when they're gone. And over the next 30 days, she continues.
Your Honor, I'm objecting to the word sneak. She went, there's no evidence of sneaking.
Goes back into the house. Let's continue.
Now, she then, over the next 30 days, continually tells different people different stories about where her child is. She tells her mother that the child is with an imaginary or fictional babysitter. She tells her friends that the child is with her mother. After a couple of days of her mother insisting that she wants to see the child, she then tells her mother that, in fact, she and the child are with this imaginary babysitter in Tampa, Florida. Let's say they're from Orlando. She isn't in Tampa, Florida. She's in Orlando. Everyone else she talks to knows she's in Orlando, but her mother, she tells that she's in Tampa with the child. After a few days, her mother asks when she's coming back. She creates another fiction of an automobile accident in Tampa, claiming that she has to stay in Tampa for a few more days because of this accident. She, in fact, is still in Orlando and still telling people, other than her mother, that the baby is with the babysitter somewhere else. She then, after a few days, tells the mother that she and the child are at Universal Studios at some particular type of event for children, and that they're staying over with another imaginary individual who happens to be a wealthy potential boyfriend. That stalls the mother for a few more days. She's not at Universal. She's not telling anyone but the mother that she's at Universal. And after a couple of days of that, she tells the mother that, oh, no, we've gone to Jacksonville. Myself, my child, and this potential suitor, we're in Jacksonville. But she's not in Jacksonville. She's in Orlando. And everyone else she talks to knows she's in Orlando. I could go on and on. You would agree with me that that type of conduct is not consistent with the type of denial that is seen in grieving mothers, wouldn't you?
I would agree that that's a young woman in crisis who is unable to figure out how to make things better. I may call that grief only because grief makes people do very unusual things. But as you described that hypothetical child to me, I would think that we needed to get her some help.
But you would agree that that is not consistent with what one typically sees in denial situations in grief, wouldn't you?
No, I would call that more magical thinking. If I can keep all these balls in the air, maybe it won't be true what I'm fearful may have happened.
Let's add an element to that hypothetical. Let's add the element that the mother killed the child, deliberately killed the child.
Excuse me. I object. There is no evidence of this.
I disagree with counsel, and the jury
That's
can make that
approach.
decision. Now, denial is you've referenced as a coping mechanism. It's a coping mechanism for things other than grief, isn't it?
Oh, yes.
Denial is a common coping mechanism for guilt, isn't it?
Can be.
Not been proven. This is speculation. It
Overruled.
must be fact specific.
In fact, it is.
This individual has not been tendered as an expert in guilt, or nor has any predicate been laid that she can testify with regard to that aspect.
Overruled.
In fact, it's documented in the literature that many people use suppression, repression, and denial as ways of dealing with guilt.
Guilt and shame.
Guilt and shame.
Right. But one of the ways that folks that feel they may not have done the right thing, lived up to expectations, and especially if they've come from an environment where guilt and shame were part of their childhood, they're very quick to go back to guilt and shame when things go badly. And that particular form of denial is something we see.
And in fact, when that happens, people essentially take that event and put it in a box emotionally. They haven't forgotten it, but it's in a box and it's compartmentalized. It's separate. And they can go on as if they hadn't done this thing that they feel guilty about. Correct?
Previous objection, Your Honor.
Overruled.
Isn't that correct?
Right. The only codicil to that particular statement you made is often they didn't do a thing and still feel guilty and at risk and shameful because of another event. And so compartmentalizing traumatic episodes is a typical way of being able to continue your life. Now, what we can see is secondary PTSD symptoms in these folks.
But you can compartmentalize a deliberate, horrible act that you committed, can't you?
Yes.
So one could commit an unspeakable act and compartmentalize.
I'm going to object based on what we discussed previously.
Overruled.
Commit an unspeakable act and put it in a box and go on as if, in fact, nothing had happened. Isn't that also?
Well, what I would say to that is that falls more under the purview of someone make a psychiatric diagnosis. That would probably, there could certainly be grief involved with that, but I don't see that is part of the way I would treat a patient like that, because I would see that that's for another professional.
So that would be outside your purview.
It would, in terms of my making those kinds of diagnoses.
So if it doesn't involve grief as a reaction, then it would be outside of.
Grief and trauma and loss, and recognizing that it's not just death that comes that way, and that people have many forms of loss, and there is a point where they may just be in a bereavement overload. Parents of children who are have disabilities live with chronic sorrow all the time and often feel guilt and shame, and it isn't associated with having done something terrible, but that they aren't going to be able to care for them forever because they'll get old one day, and who will take care of these children. And so that chronic sorrow that goes with that.
Now, guilt can come either from some truly horrible act or some
Imagine that.
some relatively minor act. In other words, lying to somebody can make some people feel guilty,
Yes.
correct? And even that type of guilt can be compartmentalized. You can lie to someone and appear to be completely truthful, show no outward signs of lying, because you've compartmentalized your lie in a little box and you don't show it. That's also part of denial from guilt.
Well, that's one way to look at it. The other way to look at it is that in an attempt to stay afloat, they may create an environment that works for them, because to look at their past life, for example, or to think about how they've been raised or what kind of things are expected of them, they may very well come up with an almost merry discussion about activities.
And people have an amazing ability to rationalize and compartmentalize the things that they do. Isn't that true?
We all do.
We all do. You can convince yourself that something is best for everybody when in fact you know it really isn't.
Well, you may not know. If you convince yourself, then you don't know. If you are evolved and insightful enough to actually be able to evaluate at that level, those people may very well know it's not good for everybody. But with many folks, they believe exactly what they think they believe, and magical thinking becomes integral to their personality.
Well, now, magical thinking, do you mean by that actual delusions? In other words,
No, I don't mean delusions. I mean magical thinking. If you'll let me, I had a mother the other day who lost a child.
Go ahead.
And the first rainstorm, she called and said, he's never been in the dark and in the rain alone before. And I said, then I'll be right there, and we'll get a blanket, and we'll get some umbrellas, and we'll sit out there until the rain stops. Now, that was certainly magical.
Right.
But it was also something that we needed to do.
But intellectually, she knew the child was dead. But emotionally, she couldn't accept it.
Academically, she knew that was true.
Sure.
Emotionally, the need to protect that little guy was
there.
just there. And so I will tell you, in many years, I have lots of folks do things and ask for things that seem exquisitely unusual. And I've usually helped them do many of those things like that.
And you would agree that the bond between mother and child is hard to break even with death?
I don't think it breaks.
No further questions.
Any redirect? May the doctor be excused.
Yes, sir.
Yes, sir.
Thank you very much, doctor. Thank you.